We now welcome Dr. Harminder Dua, who needs absolutely no introduction. We have none other than Dr. Dua here with us, taking us through his journey of finding this new corneal layer.
My pleasure, and thank you very much for this kind invitation. I looked at this word youthful, and it sort of itself tells you a lot. It's young people. But then when I looked at what that acronym meant, that seemed like quite a mouthful. But I think it is apt because in these days we have this hybrid facilitation of unique learning, and it fits in very well with that. So I'm going to give you, under this umbrella of insight into the mirror of our eyes, something about the Dua's layer. And because you had written to me, how you discovered it, was the understanding of the layer and application, it fell in nicely into a DUA kind of 3 words. Looking at what somebody said many years ago, a doctor is a student all his or her life. In other words, when he or she ceases to be a student. So an ophthalmologist is always young. Our field is advancing at such a tremendous pace in instrumentation, microsurgery, medication. It's right at the front. Imaging, absolutely amazing how much we have advanced. 80%, almost 90% of what I do today, I did not learn as a student or a resident or even a fellow. All that learning came afterwards. So it's a process of lifelong learning. Therefore, you have to stay forever young. You're either a young ophthalmologist or a dead ophthalmologist. On the journey of corneas and how we came to this layer, this is how it started. This is how cornea transplants were done in the early days. And I've actually seen patients with these eyes in my fellowship in Philadelphia. I tell my son, this is how your eyes will become if you watch too much television. It's square grafts. But despite over 100 years of penetrating keratoplasty, these problems never went away. Rejection and non-rejection failure, stem cell deficiency almost always resulted in failure of the graft. Even when you had a very clear graft, you still had a lot of astigmatism and vision could be very poor. And the graft-host junction was forever weak. A little injury and you get dehiscence and rupture of the graft and the whole thing gets undone. And this is a cartoon where somebody has said, as a method of checking cornea grafts, this hurdle course, it is crude but very effective. And these were the problems we tried to solve with science, but the answers came through surgery. Deep anterior lamellar keratoplasty for those listed indications did away completely with endothelial rejection, and stromal rejections was much less. However, the problems of graft-induced, graft-host healing-induced astigmatism, suture-related problems remain. But the graft was for some reason stronger than a PK, and everybody who did DALK recognized that. And then came along endothelial keratoplasty for those listed indications. And with endothelial keratoplasty, we completely did away with all the problems of sutures and the graft-host junction, which is a circumferential cut. But the problem of endothelial rejection remained, even though that was much less than with PK. And this is where my journey started. So we were doing DALK. So we made trephination to deep lamellar depth, a drop-off helon to magnify the tip of this 30-gauge needle. And then we put this 30-gauge needle bevel down into the stroma and you inject air. So when you inject air, and everybody is familiar with this, you get that white ring. It goes up to more or less up to the trephine mark. And then you take away the top half or 2/3. The bubble is still in the eye. But the important thing was we all called this at that time the Desmets bearing technique. In those days, we used to put a spatula. This is one of my early cases, and then do this cruciate incision and cut it off. But nowadays, I fill it with viscoelastic and cut it with a blunt tip scissors. And then you expose what was at the Desmets membrane and put on top of it a cornea from which the Desmets membrane has been removed. Now, certain early clues which were telling me that there is something different. The first one of this is this Desmets membrane was pretty resilient. You could bounce a forceps off the top of the Desmets and it would bounce back at you. It seemed like a very strong layer, which is not what we were used to seeing the Desmets as when we saw Desmets detachments after cataract surgery. And the other thing which struck me as odd was that when we do a penetrating graft, so there's no air over here, so you can see the penetrating graft, when you put the needle, we were taught never to go through and through in adults, emerge just anterior to Descemet's membrane. You can see that Descemet's membrane standing out as a proud line, and the needle is emerging anterior to it. Now, bear that in mind. Now, here is the donor for a dark procedure from where the Descemet's membrane is being peeled off. And look how smoothly this Descemet's membrane comes off from the donor. So also bear this point in mind, because we'll come to these 2 points, the edge and the ease with which the Descemet's peels off in the next 2 slides. So that's taken off. And now when I'm suturing that donor onto the patient in the dark, you can see, I still see that edge. So if that edge is produced by the Descemet's membrane and I have just peeled it off, why am I still seeing that edge? So that didn't add up. So that was another clue. And then sometimes when the bubble doesn't go as far as the edge of your cut, you have to separate the Descemet's membrane from the deep stroma. And you see these strands. Now I showed you how easy it is to remove Descemet's from deep stroma. Then why should there be collagen adhesions between deep stroma and Descemet's when I'm trying to remove it the other way around? So clearly there is something different in these 2 planes. It is not the same. You never see these strands when you're peeling off Descemet's from the donor of a dowel. That was there. And then there were, when I looked at histology slides, I always found there's a clear area between the Descemet's and the last row of keratocytes. That sort of, some of these little things you file away in your mind until then they all start adding together. And this paper of 1978, John Marshall is looking at the evolution of the Descemet, not the evolution, rather the thickness and the development of the Descemet's membrane from a 20-year-old fetus over there. This is high power. Then this is 5 days. And then you can see over here, the Descemet's membrane in a 27-year-old, and then here in an 87-year-old. So the Descemet's membrane increases in thickness with age. There's a very, very interesting paper on electron microscopy from the front to back of the cornea. But what even John Marshall didn't pick up is that this clear area between Descemet's and the last row of keratocytes is there and also increases over here, you can see, and over here with age. So there's something over there that is worthy of investigation. So we hypothesized that there exists a distinct layer in the posterior stroma that is different from the Descemet's. And we said the plane of cleavage that we get, therefore, could be in 2 different planes. And we call this the Pre-Descemets layer. And I had 2 presentations on this. One was in the Royal College of Ophthalmologists meeting in 2007. And then in the Sir Nicola's meeting in Lecce in Italy, again in the same year, where we presented this as the Pre-Descemets stromal layer. And on the basis of that hypothesis, we said, let's now test it in cadaver eye bank eyes. So here we inject air in a cornea. You may have noticed the circular movement of air along the periphery. There's a bubble that starts in the middle. Notice how much air is escaping at the periphery. All these are relevant things we'll come back to. And then you find this bubble starting in the center, expanding towards the periphery, never goes right up to the periphery, about 8.5, 9 millimeters. And there's that area over there. So that one is what we call the type 1 bubble. And in some instances, we found this happening. Now look again, that circular movement of air along the periphery, then the air comes in, but this is a tiny bubble, thin bubble, starts at the periphery and goes across the entire cornea. So here's another example. Again, you notice that clockwise, anti-clockwise movement of air escaping at the periphery, a thin bubble starting, another thin at the, these bubbles in all 3 examples I showed you start at the periphery, move in the center. And this was different to that first bubble. We call this the type 2 bubble. And there were also occasions when there was a mixed bubble. We got both these types. You got a very large central one like before, but here there's a horseshoe shaped type 2 bubble at the periphery. And here again, you can see there is a type 1 in the center and a crescent of a type 2 bubble at the periphery. So we call this mixed bubble. Now, all 3 types of bubbles were seen by surgeons in surgery intraoperatively during DALK. And they called it the white margin bubble, the clear margin bubble, or the explosive bubble, and the mixed bubble due to a split in the Descemet's membrane in the banded and non-banded zone. So that is the explanation that was provided. And even in textbooks, it was written that the mixed bubble that you get are due to a split in the banded and non-banded zones of the Descemet's membrane. So my eureka moment, as I called it, was this. So we created a type 1 bubble and we peeled the Descemet's membrane off it, and we found that the bubble did not deflate. So there was something else there holding this bubble in place, and that something else was impervious to air. Air did not go through it. And there you can see there is some roughish appearance of this layer, very different to that appearance of a Descemet's membrane. Now, when you do histology of the Descemet's membrane that you take from a type 1 bubble, a type 2 bubble, or from a mixed bubble, what you find is that there is never a split between the banded and the non-banded zones, and that's your endothelial cell. So we never found a split even in the mixed bubble. So clearly, we were onto something very different to what the explanation that was provided. So this was another experiment just to tie up things. So there's a nice type 2 bubble. So look, when I try to peel the Descemet's here from a type 2 bubble, the bubble immediately deflates, very much unlike a type 1 bubble. So that told us, okay, there's something else going on here. There's this other layer underneath. Now, can I take the Descemet's membrane off and can I put air inside and recreate a type 1 kind of a formulation of the bubble without the Descemet's? And surely you can. You can create exactly that appearance. Of course, here the Descemet's is taken off. In the type 1 bubble, clinically, the Descemet's is there, but the Descemet's is not necessary to create this bubble, which we call in the type 1. It occurs independent of the Descemet's. So that was the clinching kind of evidence, and we put it all together in the paper. But there was this other thing, why doesn't it go to the periphery? So let's push air and see how far you can. And you can make it go a bit. Notice the air escaping at the periphery as well. But at one point, it bursts. And that was about 700 millimeters of mercury. You can take away the Descemet's membrane. And when you take away the Descemet's membrane, you can see there's this layer. And this layer is very translucent, resilient. And if you pull it, you can see the stria going right to the periphery. So the layer does extend all the way to the periphery, but it does not separate with air beyond a certain distance. So that is what was born out of this experiment. And then, of course, you look at it routinely. You can do electron microscopy, scanning EM. You can see this edge of the layer. That is the layer there. And this is the Descemet's membrane. Here again, the Descemet's membrane and the endothelial cells are removed. And you can see underneath is the posterior surface of the pre-Descemet's layer against which the Descemet's membrane is apposed. And again, we did the transmission light and electron microscopy to show that's the layer over there. And it was without keratocytes in the majority of cases. That's your Descemet's membrane and the endothelial cell. And we then characterize the structure, the collagen structure, the interfibrillar distance, the fibril size, and so on, and established all those parameters. And here again, on a scanning electron micrograph, you can see the type 1 bubble. This is the layer over here. And sometimes there are strands that extend between it and the deep stroma. These are the strands that we were trying to separate, which I showed you earlier, which you never see between the pre-Descemet's layer and the Descemet's membrane. Here you can see there's a pre-Descemet's layer. That's the edge of the air bubble, and that's the stroma above it. A very distinct, clear layer. The Descemet's membrane has been peeled off. So we published this paper, Human Corneal Anatomy Redefined, a novel pre-Descemet's layer. Now that's where the full stop was. We had stopped there. Then two of the authors, Lana Faraz and Dalia Syed, both ladies, they said, we've got Bowman's layer, we've got Descemet's layer. Why don't we call this Dua's layer? I said, well, that's for people to call, not. But anyway, they twisted my arm. Didn't have to twist it too much. I said, okay, let's put it in brackets and see what the reviewers say and what the editors say. None of them objected, and it got published as such. And immediately there was a lot of publicity. It became the most downloaded paper from the journal in the first 3 months following publication. And it was the 11th most downloaded paper amongst all papers in medicine and dentistry. It was one of the 214 F1000 prime recommended articles. And it was a list of the top 25 papers in ophthalmology, number 12 in 1 year, in the year of it was published. And in 2014, we got this very prestigious Times Higher Education Research Project of the Year award. So this is across the 135 odd universities in the UK. Every faculty, so it's engineering, it's medicine, physics, chemistry, forensic medicine, botany, zoology, humanities, you name it, aeronautical, and every specialty can submit a paper or a research project for this award. And we were amongst 5 that were shortlisted. There was a botanist, there was an aeronautical engineer, forensic scientist, and there's 1 or 2 others, and we got this award. And this award was in 2014. So here's Dr. Said, Dalia Said, Lana Faraz, myself. The other authors couldn't come. These were the sponsors of the award. And the university then put this notice on every gate of every campus. And we have 3 campuses for the university across the city. Times Higher Education Awards winner, research project of the year. So that was quite a proud moment. And they kept this notice going for 2.5 years, and then they took it down. And then this lady from Paraguay, Arndale, her name is, this lady here, and she said she is doing a project on replicating this whole thing with bubbles in models. And could I give her an interview, which I did, and could she use some of my material, which I sent to her. And she then presented this in their regional meeting, and she won the first prize over there for this presentation. And she was selected then to present it at the International Conference of Human Anatomy and Morphology. And there too, she won the first prize. And then this lady from Sweden sent me this cake, and this is a 6-layered cake, and apparently the green layer was the Dua's layer in that cake from Sweden. So you can, from Norway, sorry, you can see what she's written over there. So there was a lot of excitement, sort of mixed feelings across in the ophthalmic world. And then one of my ex-fellows and his wife, Amir Mary, she baked this cake, which Rita and I then had shared with them in their home after a meal, and they called it that cake again. It's supposed to have that layer which is hidden behind the ribbon around the cake. Now, whenever you discover something new and you present it, it evokes 4 kinds of responses. First is, it can't be true. Second is, oh, it's been described before. The third one is, I have described it before. And the fourth one is, okay, well, let's see, let's test it, let's check it out, let's validate it and see if it's really there or not. So that are and this paper had all 4 kinds of responses in editorials and comments and meetings, as one would expect. There was an editorial in the same issue in which the paper was published, which also was one of these, saying that it's been described before. The editor wrote at the end, there is nothing new under the sun, and they attributed it to somebody. They said something like that before. And I responded with a letter, which was also published, that yes, there is nothing new under the sun, but the sun is constantly shedding new light on old objects. And that is true. But it is interesting that as soon as the paper was published in online in 2013, there were lots of comments. And then one of them, I'll just pick 1 or 2. One of them was, great discovery, but what the hell is he wearing on his head? Give me a break, it's the 20th century. So that sort of evoked a lot of rebuttals from a lot of people. You're ignorant, you don't know, he's a Sikh, he wears a turban, and you don't know anything about religion. And they forgot the layer, and the whole argument and discussion went down Sikhism and Sikhs and religion. And then somebody put a comment, it's not what's on his head that matters, it's what's in his head that matters. And then the other one said, what did Jesus say to Harminder Dua? And the answer was, seek and thou shalt find. So I found these were some of the interesting comments I would share with you. But then this whole journey took off from there. Is that, okay, let's go and see what is happening. There's so many other bits of information that this had thrown up. Now, when you inject air in the cornea, it just doesn't form a bubble. If you look at every second that goes by, it's interesting. So air, from no matter where you inject, it shoots back radially, 1, 2, or 3, or 4, like over here, spokes to the periphery. The first one that hits, so there's a needle over here, it then starts making that other movement. But it can be a diffuse spread before the spokes come. It can be like cracks in a glass spread, very much like that appearance of little lines or cracks. It could be a combination of the diffuse and the cracks. And this is very, very reminiscent of this infectious crystalline keratopathy, which represents the path taken by bacteria in the compact stroma of the cornea as they migrate in the absence of the host response that you often see in a PKI, in a keratoplasty eye. So it was telling us this, the passage that air takes in the cornea, giving us clues on the microanatomy of the cornea. And then what happens is, as soon as one of these tracks reaches the periphery, it starts this circumferential movement clockwise and counterclockwise, till they meet. And once they meet like that, then the air starts to move centripetally back to the center. This is so consistent a movement. We see this very often even when we do DALK, but because in DALK we've got a big refined cut and a lot of air is escaping from that, we don't see the whole picture all the time. Here, there is no cut. Therefore, the air takes its natural course in the stroma. And the point here is that why is this air going preferentially in that area? And again, we did some, you can show that completely emphysematous peripheral cornea. So there's something different about the periphery of the cornea than the center, and then the whole passage of air moving centripetally and forming the bubbles as we see. And sometimes you can have a mixed bubble complete. So you get a complete type 1 bit in the middle, and then the outer one is the type 2, the Desmets. So air between Desmets, the Pre-Desmets layer, the Pre-Desmets layer, and the stroma. And this is a scanning electron micrograph. So what you see is that the Desmets has been cut. Here is the area in which the circular movement occurs. This is about 1 to 1.5 millimeters. And this is your type 1 bubble. So this is one quadrant of the cornea. That area where the layer does not separate, there are, I won't go into the details, there's lots more to the anatomy over there, but that's where this circular movement occurs. Now, if you flip the cornea around, and you will see that's exactly where the cornea starts to flatten in our prolate-shaped cornea, and that's where the periphery which is flattened, that corresponds to that band where the air moves and where the bubble does not form. So again, a lot more in there still to be explored, and we're working on some of that. In one of my lectures in Warsaw, Natalia came up, and this was a gentleman who was a VR surgeon who presented in the middle of his VR talk. He just stopped to show these two slides and he said, now I believe in the Dua's layer because this patient had a silver nitrate injury. The whole cornea went brown except the Dua's layer. Just between Desmets and the last row of keratocytes, there was that band, which he said was different to the rest, and it did not stain with the brown stain that the rest of the cornea did. But of course, there were questions, and people did have very valid questions. The average age, I think, of the patients we had done our studies was 70. So is it present in children? And I was in Trivandrum, and Vinay Pillai came to me with these pictures. So he had a young, I think a 9-year-old child where he'd done a DALK. And everything went perfectly normal, but the DALK never cleared. But look at the OCT. What the OCT is showing is that that's the Pre-Desmets layer, and he had a mixed bubble, but the inner part, the Desmets, had torn and curled. So what was happening is that clearly there was edema because there was no Desmets, no endothelium lining to the DALK inside because of the mixed bubble and it had torn, and therefore that had not cleared. So they did a PK, and we had the histology, and the histology showed that there was a Pre-Desmets layer and the torn and curled Desmets membrane. And then thereafter, with Amar Agarwal, we were able to show it's present in a 1-year-old child over here. There's a 2, and we had the different ages over here. Yeah, so 1 year, 3 weeks, even we have shown, and even in a 3-week-old child, you can get type 1 bubble. 1 year, 4 year, 9 years. So yes, it is present in children. Then the other criticism came, oh, this is just a stroma. It is random separation of the deep stroma. And this is the picture that most of the press had and appeared in a lot of newspapers. So the Desmets membrane has been removed. This is a light micrograph of the Pre-Desmets layer and the air in the stroma. So that is random separation of the deep layer. And I said, okay, that's a valid question. How do we show it is or isn't? So this is what we did. We took a human cornea. We then peeled away the Desmets membrane completely. It comes off quite smoothly, as I showed you. And then we flipped it upside down to do PTK. So we knew what the thickness of this layer is. So we put it in an artificial chamber, fill it with BSS, and do PTK now to ablate this layer. Now, if it is random separation, you ablated the Pre-Desmets layer, you put air, you should get another bubble. And look what happens. We did many eyes, and all of them consistently showed this picture. Multiple leaking spots, they never can make another bubble once you have ablated this layer. So clearly, it was not a random separation of the deep stroma. So that paper was published in ACTA. And you can see over here, that is the layer right here. And you can see that's the part which would have formed the bubble. And that is the part that had been ablated by the PTK. So we then said it's below the last row of keratocytes. And the criticism that came was, oh, well, it's not below the last row of keratocytes. We can see keratocytes in it. and that it's of variable thickness, is not of consistent thickness. Now, so this is my diagram to show what's happening. Keratocytes are standing in rows like soldiers. You would say that is one layer and that is one layer. But keratocytes don't stand like that. They are random. So is this one layer, or is this a layer of keratocytes, or is this the layer of keratocytes? Which is the last row of keratocytes over here? Now, according to what I propose, it is this red line, which is the last row of keratocytes. And this is the last row of keratocytes. So if you draw your line on the top here, you will say, oh, there's a keratocyte there. But if you draw your line as this red line, then you will not only have no keratocytes beyond it, but you will have a variable thickness of the layer, which is actually here. And that is some of the collagen that separates out just at posterior to the last row of keratocytes. But that's the real compact layer over here. And the green is to represent some elastin in it. So we then found this paper published by a completely independent group of researchers in Canada. And this paper was ultra high resolution OCT of the human live cornea. And they found exactly what we had said. So they even correlated it with histology. Last row of keratocytes, those red arrows, that's the layer over there. Now remember, the Descemet's membrane always produces a double contour line on OCT. And in ultra high resolution OCT, it is very, very apparent. Because OCT is not histology, it tells you difference in refractive index. The difference in refractive index between stroma and anterior Descemet and between Descemet and aqueous, so you get this double contour line beyond the last row of keratocytes. And they even used, at the time when people were also arguing whether the name should be Dua's layer or not, they had used Dua's layer as one of their keywords to show it was there. And again, we were able to do other whole mount preparations of the layer. You can see this quite a wide amount of the layer, and there's not a single keratocyte. You can see some keratocytes there in the strand that holds it, because that's peeling off the deep stroma, but not in the underlying pre-Descemets layer. And here's a bit of Descemets and the pre-Descemets layer, and you can see some of the endothelial cell nuclei visible, but there is no nucleus at all within these sheets. So we still maintain that it has very little, if any, keratocytes. Then there was this paper from Keith Meek's group in Cardiff, showing that there's a very high concentration of elastin in the pre-Descemets layer compared to the rest of the cornea. And these yellow lines, and they did this by on-face scanning electron microscopy. So they cut a piece of the cornea in nanometers, do scanning EM, then cut another piece, do scanning EM, and then build a lot together. They found very much more elastin over there. So we did the same thing. We extracted elastin from the pre-Descemets layer, Descemet's membrane, central cornea, peripheral cornea, trabecular meshwork, sclera, and we found the highest concentration of elastin was in the pre-Descemets layer, not in the Descemet's membrane, in the pre-Descemets layer, which is not statistically significant from what is found in the trabecular meshwork, but it is statistically significant different from anywhere else. But here is the key finding. The pre-Descemets layer, all green is elastin. So you can see the pre-Descemets layer has a very, very dense layer of evenly distributed elastin. The Descemet's membrane, on the other hand, has a dense band of elastin anteriorly. And this is the combination of pre-Descemets layer and the Descemet's membrane. You can see that band, which is this band here. The pre-Descemets layer is very green, and the Descemet's membrane does not have it. And here, partly the pre-Descemets layer is removed. And if you do a section of the cornea, the whole cornea, here the layers were removed, but here you can see that's the Descemet's, that's the band of elastin. There's this interfacial matrix, which is dark, and then the pre-Descemets layer, which is very green again, and then the corneal stroma, which has very little green, if any. So it's not only a bubble-induced layer that is coming, it has a structural difference from the rest of the cornea. And if you take this tissue, which is now we know is what we call PDEC tissue, but we'll come to that in a minute or two, it scrolls much less compared to if from each of these you peel off very carefully the Descemet's membrane from the pre-Descemets layer, and you'll find the pre-Descemets layer on its own doesn't scroll much at all. The Descemet's membrane scrolls a lot more, and this scrolling of the PDEC tissue, which is a combination of these two, is due to the Descemet's membrane, not due to so that on its own doesn't scroll at all. Now, those of you who do DMEK know how important this scrolling is for understanding, the that the cells are always on the outsides for the orientation of the Descemet's membrane as we put it in the eye. And the explanation given for that was the endothelial cells are always on the outside because the endothelial cells are swollen and they make it roll inwards, so the cells stay outside. And the other explanation is because of its elasticity. But yes, elasticity is fine, but why should elasticity make it always go one way? So we propose that this band of elastin, which is on the anterior part of the Descemet's membrane, will make it scroll in this direction. And to prove that, what we did is we took Descemet's membrane and we put a drop of elastase enzyme. So this is the scroll of Descemet's. You put elastase and leave it, and over time, what you find by itself, the Descemet's membrane unfolds and becomes flat. So here it has started to unfold, and here you can see the Descemet's membrane will become completely flat. And if you then do a section of this, you can see the band is completely fragmented compared to the control where the band is nice and clean as it should normally be. So clearly this elastin band, which is the preferential distribution of elastin, which causes it to scroll outside. And what about the endothelial cells? So if you take the endothelial cells and you Descemet's with endothelium and you gently tease it off or take off the endothelial cells with dispase enzyme, you will find here the cells are gone. It will still scroll, and you put an F mark to know which way is the up way. You find that it still scrolls. So the endothelial cells do not play a role in this scrolling at all. And this is my little crude animation of that. So if you take a rubber band, okay, and you pull it and you leave it. So the elasticity, it comes back where it is. You pull it and you leave it. Now, if you take this and with my third hand, if I pull it down, what's happening is that's what happens in DALK. The whole thing goes down with the air and it comes back up. But now, if I put glue on this elastic rubber band and you stick it to a strip of paper. Now, this is my Descemet's membrane with the anti-elastin band. So again, you just press the glue down and then you leave it. So what happens now, you see, this paper, the strip of paper, which is your Descemet's membrane and the rubber band is the elastin band, it will scroll with the endothelial cells outside. And because the elastin band did not go to the full length of the paper, you have those bits sticking out. But if you trim those bits off, you will find that it actually forms a roll within itself. So if you take that elastin band and put it almost the length of the whole paper, you can find that it scrolls exactly like the Descemet's membrane would do. But there is the explanation why the Descemet's membrane always scrolls with the endothelial cells outside. But God didn't make it there for us to do DMEK. There is a physiological role. And the physiological role is this, that you can see how this Descemet's membrane has to be opposed to the cornea without any physical attachments at all. And it should not bear the brunt of any shearing force that as is induced by squeezing the eye, rubbing the eye, blinking. Yet it has to stay opposed to keep the cells functioning and taking out water from the cornea. So if you can see my hand, that's what I'm saying. That elastic band is making the Descemet's want to scroll in this direction of the arrows, and that's what's keeping it firmly pressed against the back of the cornea. Now, a lot of people do DALK by viscoelastic, and this is interesting. So if you try and do DALK with viscoelastic, you get a fourth kind of bubble. It depends on where your needle is. If your needle is quite superficial, you just get a diffuse spread of the viscoelastic. If your needle is mid-stroma, you might get some mid-stromal separation, but the shearing force of the viscoelastic tears the stroma to give you what looks like a type 1 bubble, but there's variable thickness of the stroma underneath. It just rips the stroma apart. So you may think, and clinically, when you do the operation, it looks exactly like a type 1 bubble. You will cut that off on the top, you will make your choose it and take it off. But what you've left behind is very, very variable. So all of those people who are doing DALK should go and do OCT of their patients post-op, because often you will find that a type 1 bubble, we call this the intrastromal big bubble, the IBB. But if you're deep enough, you will get a nice type 1 bubble. You will not get a type 2 bubble. But people who do viscoelastic bubbles say we get a type 2 bubble, and they've called this a type 2 and this a type 1. And that's completely wrong. You get a proper type 1, and it's very, very difficult to get a type 2, a true type 2 bubble with viscoelastic, at least in our experimental eyes. So what are the clinical applications of all of this? You can tell clearly no prizes for guessing which is type 1 and which is type 2. So anterior surface of Descemet's membrane is this, not this, which we used to call the Descemet sparing technique. When you see this rough appearance, then that is a type 1 bubble. This is all intraoperative. And when you see like this, there's still an anterior chamber, and you know this is Descemet's, that's a type 2 bubble. Very difficult to predict which one you're going to get, but very important to know which one you've got, because this one can end up in disasters and you can have lots of problems if you've not recognized it. And these are some of the problems. So imagine you've got a bubble like this, a type 2 bubble, and you may or may not have a type 1 underneath, but here I've chosen this example as a mix. Now, if you do a paracentesis, now imagine you're looking at this from the inside, it's actually going to be the other way around in the human eye. If you do a paracentesis like this, you're going to burst your Descemet's. So when you get a type 2 bubble, you will see it going all the way to the periphery. Then don't do a paracentesis until you've released the air from the top. But if you get a partial type 2, then you will do a paracentesis not from here, but from the other side, because you don't want to break the Descemet's over there. The first clinical, here's one. Remember this, we didn't know what was there. Look what happened. You're trimming the edge and it's gone, right? That was a type 2 bubble, and the whole Descemet's around the circumference, just by nicking it there, is gone. We can completely avoid that if you know it's there. So the way to avoid it is do repeated paracentesis. Keep releasing aqueous. Keep the Descemet's flaccid, and it will not burst on you. You keep it taut, the slightest touch like a balloon is going to burst on you. This is another example. This is Kana Ramesh, a colleague from Glasgow. He has done a DALC. He's put the new cornea on it without the Descemet's. He holds the eye at one point and then moves the eye, and see what happens here. So just that, and the whole eye has burst open. So because he didn't have a spare, so it's a long story with this patient, very interesting story, but that can happen if you don't recognize which type of bubble you've got. And you can completely avoid this by not doing these maneuvers that increase the eye pressure when you've got a type 2 bubble. A type 1 bubble, you can do anything, it's going to withstand that pressure a lot. So here's a type 1 bubble, and see what has happened. I've got a tear here in the bubble, and I'm trying to fill it up, and I will soon go with my cannula and prod through that. So when you get a tear in a type 1 bubble, with the Descemet's supported by the Pre-Descemets layer, it's not a big deal. You can do your DALC, and that will seem, you might get a double anterior chamber, so you put air at the end of the operation to keep the PDL and the Descemet's against the back of the cornea. And this is what we had to show for it. There was a little wrinkle at that site, slightly distant from where the tear was post-operatively. This is from Hardik Parikh. So the other important point I want to draw your attention to is there is a distinct plane of cleavage between the deep stroma and the Pre-Descemets layer. Now, if your air bubble does not reach the periphery, then you can make it as though it has by cutting those strands, or you breaking them by sweeping them with a blunt spatula, as I showed you in the very early video clip, where you can separate deep stroma from the anterior surface of the Pre-Descemets layer. If you get the strand, you know that's where you are. And you can do that very comfortably because those strands are telling you you are in the correct plane. This is, again, you see how this knowledge of anatomy then comes to a help. So here's a picture of where I'm trying to do a DALC. My tip is too close. The first thing, air goes inside the anterior chamber. What do you do at this point? A lot of people say, let's convert. No, but I went to another side, put air, and I got a very small type 1 bubble. And as I burst it, you can, as I cut it, all the air from inside the eye also came out. But then, you know, there's a plane of cleavage. You can go in with your spatula, you can exploit that plane of cleavage, and you can complete your DALC as though nothing has happened. So even if you have a tiny type 1 bubble, that is your access point to the cleavage plane, and you can use it. And this is again by Rishi Swaroop from Hyderabad. They tried a visco DALC, it didn't work. So they did deep definition. You can see physically, forcefully peel out the entire stroma from the Pre-Descemets layer because of that plane of cleavage. You cannot do this with the Descemet's membrane. Of course, you won't need that much force, but you can easily tear the Descemet's if you try and force it that much. But it's not just surgeons who exploit that cleavage plane. This paper by Liu et al. Shows that fungi tend to preferentially grow in that cleavage plane. Now, there was just a couple of case reports, and they said this is providing pathological support for Dua's finding and adding clinical meaning to the new anatomical concept. But if you go back and do OCT on all your fungal cases, you will find from time to time this. This is what we found in two of ours now. There you can see that line over there. There you see that line over there. That is deep fungal keratitis. The pre-Descemets layer separates from the rest of the stroma. And that happens, we have so far seen it only in fungal, but I'm sure there's no reason why it shouldn't happen in deep-treated any type of infection. But it's an important clue to tell you this might be fungal. But this is, again, I think, one of the most important clinical applications of this whole story. We were able to show that just like the 3 types of bubbles, Descemet's membrane detachment is also of 3 types. You get, when it's a straight line taut like the chord of a circle, it's pre-Descemets layer with the Descemet's membrane that detaches. If it is a double contour line and it's sinus like this, wavy, it is a type 2 kind of a detachment. That's a true Descemet's detachment. And you can also have a mixed Descemet's membrane detachment where both have separated, like in a type 1, but also separated from each other. So that's your pre-Descemet's layer, and that's your Descemet's membrane, just like a mixed bubble. Now, we have been seeing, ophthalmologists have been seeing Descemet's membrane detachment for almost 100 years, and the reports going back, and we are treating it all the same. But now that we know about this layer, we know it's not the same. Now look at these examples here. This is when it tears, it scrolls. So look at these examples here. We had this type 1 Descemet's membrane detachment. We did a PK, and you can see the pre-Descemet's layer is on the Descemet's membrane. Here in a cornea graft, do OCT, and you can see there's a Descemet's membrane detachment. And you can see a strand coming from the deep stroma. Whenever you see that strand, you know immediately this is a type 1. This is the pre-Descemet's layer. You never get a strand with the Descemet's membrane. See, again, over here, 2 layers starting. So that's a type 1 Descemet's membrane detachment. And here you can see there's a type 1 and a torn, curled edge of the type 2. So the mixed detachment, here again, you can see 2. And this is a picture, Dr. Sinha, Rajesh from All India, Shan Souza, the number of authors from 3 different countries. But Dr. Sinha contributed the most number of patients. Again, you can see 2 lines, pre-Descemet's layer, Descemet's membrane. And here again, pre-Descemet's layer and a torn, curled Descemet's membrane. But in different parts of the detachments, here is like type 1, here the 2 layers are beginning to separate, and here it's a mix with the torn. So you can have regmatogenous and non-regmatogenous, type 1, type 2, and mixed. And this is a picture recently sent to me by Sangeeta Wagh. I think we have been able to get it accepted in the Indian Journal of Ophthalmology. Patient with a massive Morin's ulcer. And you can see that type 1 detachment on slit lamp, straight line, not a wavy line, taut, like the chord of a circle. Once all that settled, treated, that Descemet detachment that didn't go. So, but the cornea cleared. Therefore, they did a cataract extraction with implant with that in place, and they also got some cells. You can see some cells over there, this polygonal shapes on specular. So when you see that, you know it's a type 1 detachment, which is actually the pre-Descemet's layer with the Descemet's, not the Descemet's membrane. The implications for treatment are that if you leave this for some length of time, the keratocytes will move into this and cause scarring and shrinkage. So then you have to do a desmetatomy. So now you know if you've got a type 2 detachment, which is pure Descemet's membrane, air or SF6, carbon hexafluoride will work. If you've got a type 1 detachment and you put air, it'll go back. As the air goes out, it'll come back. It'll just bounce back. So you have to release it over there. So all the huge clinical implication in terms of management of these detachments, you have to know which type you have got and for how long, because the longer this stays, the more difficult it is to put it back. Desmetocele, again, this has been published. So many desmetocele have actually got the pre-Descemets layer on it. And this is from Sunita, from the Tej Kohli Institute, where they've shown, and we've seen many of these. And you go do your OCTs or desmetocele, you will see a lot. But again, a very, very important finding. We postulated in our very first paper that we published in 2013, acute hydrops is due to not tear in Descemet's membrane alone, but due to a tear in Descemet's membrane and the pre-Descemets layer. And on OCT, you can see it's a tear in both the layers. Acute hydrops, vacuoles. Now, even people at the time who did not believe in this layer, and Jared Mellis was one of them, was skeptical early on. He has gone and shown something I'll show in a second. So here again, you can see a type 1 detachment, acute hydrops in this patient, an eccentric graft, but this was in a pellucid. You can see the 2 layers separating, but there's a strand that tells you this was a type 1 detachment and there was a rip. Based on this, Professor Muran proposed a way how to resuture the torn edges of the pre-Descemets layer only without having to resuture the stroma, the Descemet's membrane, only the Pre-Descemets layer. You can reduce the eye drops very quickly if you do that. But this is what I meant. What Mellis was doing was he was trying to do Bowman's membrane transplant, and post-operatively he found some patients of his had Descemet's membrane detachment. They did not have any eye drops. But in patients where they had inadvertently perforated into the eye because of thin cornea, they're trying to do Bowman membrane while they're creating the cleavage plane to put the Bowman's membrane in, and they penetrate. Whenever they penetrated, they got acute eye drop. And they then said, yeah, we agree, acute eye drops will only occur when there's a tear in the Pre-Descemets layer and the Descemet's membrane. So they published their paper, and we wrote back a letter to them, because what we had done is we had tried to simulate acute eye drops in eye bank eyes. So you make a little cut in the back of the cornea, and then you put it on an artificial anterior chamber, and you raise the pressure even to 60, 70 millimeters of mercury, you never get acute eye drops. So we never published that bit of data, but when we, in our response to his letter, we said that, so you need a tear in the Pre-Descemets layer in the context of the abnormal collagen of keratoconus, the abnormal stroma of keratoconus. It does not happen in normal corneas. And that's what we wrote in the letter. And then they wrote back saying that we thoroughly agree with the primary point of the letter, namely the acute hydrokeratoconus was a result of tear in both Descemet's membrane and the Pre-Descemets layer in the background of the abnormal collagen of the corneal stroma. So that is another little mystery of the pathology of eye drops added to the explanation. And then this is the triple DALK procedure. This patient was doing a DALK. He found a dense cataract underneath. Ahmed Zaki, a good friend from Cairo, and he did the whole cataract operation with implant underneath. In one patient, there was PC TED, the vitrectomy, and put an implant. And then we called it the triple DALK. So you can, under the Pre-Descemets layer, do a cataract operation and implant if you're doing a DALK and you find that there's a very dense cataract. Of course, you never try it with a type 2 bubble, only with a type 1 bubble. I'm not going to do, because we're running out of time. I think I've told you a lot. But this point about PDEC, this was the video I showed in Rwanda many years ago. And Amar Agarwal then came and said, what are you trying to say over there? Can you give me that video, take me through it again? And I said, this is where we can make a construct of the Pre-Descemets layer and the Descemet's membrane for endothelial keratoplasty. And this is the very first video, which is actually published in our first paper, which I showed him. And he said, do you mind if I do the operation? I said, no, of course, let's collaborate. And we did it. And he did the first few cases, and then we published it. So he called me long distance on WhatsApp saying, I'm going to call this DLET, Dua's layer endothelial transplant. I said, don't do that, because not many people like the term Dua's layer. So let's call it PDEC, Pre-Descemets endothelial keratoplasty. So that's what we called it. And then I told my team over here that we're going to publish this paper. It's going to be called PDEC. So one of them said, never mind, we can still be Prof. Dua's endothelial keratoplasty, it'll be PDEC. So there was all that little side stories to this. And I just want to finish off by telling you that this layer actually continues as the trabecular meshwork. The Pre-Descemets membrane ends, but the Pre-Descemets layer opened up to form the trabecular meshwork. Here you can see is the Pre-Descemets layer, Descemets has been removed, and the trabecular beams are nothing but the extension of that. So we've done a lot of work on that to show, and this is the example. If you have a scarf with wool, that is your Pre-Descemets layer, that is the trabecular meshwork. And in the periphery of the cornea, you can see trabecular cells, which are very different to the keratocytes. You can see basement membrane. So, and there are adhesions between the trabecular cells and the basement membrane in the stroma of the cornea at the periphery. And that is another story, which I will leave it for now. Here are those adhesions. Talking about PDEC and the air escaping at the periphery. So why does a type 2 bubble always start at the periphery? Because if you look at where a type 2 bubble starts, put a mark there, then peel the Descemet's off, you will see clusters of holes. And you see these clusters of holes at the periphery. There are many such clusters. There are about 15 to 17 clusters, about 50 to 60 microns, average 20 microns of these holes. So if this is a very high power scanning EM of the peripheral Pre-Descemets layer, see how that layer is becoming the trabecular meshwork, and there are holes there and some holes here. So if that's where the Descemet's ends, air will escape like that and go into the anterior chamber. And we all know air goes in the anterior chamber in DALK. But if the Descemet's membrane is attached here, and that is where the air is escaping. It will go anterior to Descemet's membrane to produce a type 2 bubble. So that's why a type 2 bubble always starts at the periphery. So based on that, we said, if you want to avoid a type 2 bubble or in PDEC, then you can clamp these holes off. So we invented this clamp, and that's the clamp, and you can clamp the tissue, inject air, no air escapes at the periphery. There are other advantages of this clamp. Intertissue pressure is built up in a very controlled manner. No air is escaping, so all the air will eventually go to form the bubble, and you can consistently create the bubble if it is well centered. So that was a rather expensive solution to avoid a type 2 bubble, but it had the added advantage of very controlled injection with no loss of air. But then Nicholas from Brazil came to me with this idea, and then we just published this in the BJO. He said, forget the clamp. What we do is we'll go and completely score the Descemet's membrane at the periphery, like you do for a DMEK. Now, when you inject air, any air escaping will go away from the periphery and will not cause the Descemet's membrane to lift up like a type 2 bubble. So that's what we were able to show. Just by scoring at the periphery, you can completely avoid a type 2 bubble because any air escaping goes out and you can get a nice type 1 bubble. You don't need the clamp. But of course, here it's very uncontrolled, the injection. If you inject too much, it can burst because all the air is escaping, and you have to overcome the pressure loss with to escape air to build enough intertissue pressure to reach the cleavage plane to cause a type 1 bubble. So that is a slight disadvantage, but it is another innovation. And that's the PDEC operation. I won't go into that. A couple of slides right at the end. Yeah, I said a couple of slides twice already, so probably say it twice more. I got this letter in September 17 saying that, it is in Yanoff and Fine's textbook of ophthalmology. On a certain page, 176, in this figure, they have seen this layer. So they are therefore going to call this the fine Dua layer. This is from a letter I got from Dr. Sassani, who is the secretary of the American, I think the AAOOP, it's called Association of American Association of Ophthalmic Oncologists and Pathologists. So to permanently recognize you and Dr. Fine for your contributions. And then they put it to the board, and then he came back to me saying that the board has approved it, and we're happy to report that the annual business meeting, the members of the AAOP voted to recommend to all their fellows and members to refer to the region of the posterior cornea as the Dua fine layer. And congratulations on this great honor, etc., etc. So now it's called Pre-Descemets layer, the Dua layer, and the Dua fine layer. But story doesn't end there. If you go to that page 176 and look at that picture has been adapted from McTeague, from the Transaction of the American Ophthalmological Society, and nowhere have they mentioned anything about that layer. They talk a lot about this, the Descemet's membrane, talk a lot about the Descemet's membrane attachment to the stroma, but not anything about the Pre-Descemets layer. But it's still the Dua fine layer. And the point I make, I showed you this earlier, it was before that even, and this was in 70, whatever. This is John Marshall's picture I showed you. In his picture also the layer is there. So it's not an invention, it's a discovery. In any picture you look, whatever time it was taken, the layer is there. So maybe it should be called now the Dua fine, the John Marshall, etc., layer, because it's been found now. People are going back and looking at old pictures and seeing that it's always there. So this is the book. It's been published in the latest edition of this book. So I'll just finish off. It has improved our understanding of corneal surgical anatomy and lamellar corneal surgery, made dark safer, led to innovation of these new surgical procedures. It's involved in the pathogenesis of Descemet's detachment, high drops, some corneal dystrophies, spread of infection, and its role in glaucoma and corneal biomechanics is being explored. I'm going to rush through these slides, but I must mention Ghorpade and Morekar have shown that if you don't remove the Pre-Descemets layer when you're doing deep sclerectomy, the results are not as good as when you do remove it. So that's another experiment we are doing. But just to finish off with these slides. So that's a horse's eye, very different kind of bubbles, but here's a mixed bubble. And we've shown this consistently in the Staffordshire dogs. You get a type 1. Their eyes are much bigger than ours, so you can get a type 1 bubble in animals. So it is there in animals as well, but that's another story. Thank you very much.
Wow, absolutely impressive, sir. I think one of the most brilliant presentations that I've seen in recent times. And we're extremely proud of you and extremely honored to be with you today. What a struggle. What a struggle across the lines and to find something which is so innovative and so beautiful. And to express it to the world where there is disbelief and misunderstanding. And those sayings which you said between the sun, what lies and what you can see, and the sun can evolve every day. And the Jesus is saying, I think amazing, amazing what you have shown us, how the whole Dua's layer has got into. So, friends, you can see that he sleeps, eats, and breathes cornea. Each of these layers and each of these keratocides, we take them so much for granted. Amazing and an understanding that he's given us on the cornea. Wish we had this understanding way back during our anatomy days. And he said, whatever we do today was not there in our residency days, fellowship days, or whatever that we did in the past. Thank you so much for your time, sir. Pleasure to have you listen to all this in so much details, and you taking the pain and still being so interested to talk the nth number of time. Absolutely proud of you to see, and you're still so humble to say that it's Pre-Descemets layer. You still never in the whole talk that you said Dua's layer. You hardly mentioned that. Absolutely fantastic.
Thank you.
It's so crystal clear. So I just wanted to ask you, because Himanshu is going to be speaking on keratoconus. How much of keratoconus would be affected because of the Pre-Descemets layer? And
well, it is interesting you asked that, because we're doing studies now, and there is one paper already from Keith Meek's group that the elastin degradation in the Pre-Descemets layer is the first event in keratoconus. I think posterior keratoconus, or the posterior elevation that we see of the keratoconus phenotype, is because of the pathology in the Pre-Descemets layer. So we have got some eyes for keratoconus. Unfortunately, the elastin enzyme, the elastin staining antibody works on cryosection, but we've got a lot of eye that are paraformaldehyde fixed. So we're optimizing for that to show by this technique, it shows us much better than the scanning EM technique, that elastin degradation in the Pre-Descemets layer will be fundamental to the pathology of keratoconus.
I mean, I totally, looking at what you said right now, it just struck me that as the LASIK surgeons, we are the anti-segment surgeons, we only look up to anything before the Pre-Descemets layer. Nobody ever has talked about the Pre-Descemets or the Descemets layer in the formation of a keratoconus. If the elastic, because there's quite often that a thin cornea and you don't get a K-conus. You have a dirty, you're done, you're sure that, this patient might get it. And there are times when you see the cornea is pretty good and you've got a conus or an ectasia after a LASIK surgery. I think somewhere this elastin, what you're talking about, should come up in a big way to adhere the...
I think that the Pre-Descemets layer biomechanics will be very important for the whole biomechanics of the cornea, as well as for glaucoma. So I think it's an area where the good thing is, because when not many people agree with you, they don't go and do the research. So you get a chance to do all the research, and you can find all the new findings. But now people have started doing everywhere else. And I think a lot will come out in the years to come on all these different pathologies. In macular corneal dystrophy, the layer is affected. In the other corneal dystrophies, it is not so affected. When you take the top off, you'll find there are some opacities over there. So we believe, and we've published that, and the development of the layer is from more under the influence of the endothelium rather than the keratocytes. And because macular corneal dystrophy is an endothelial dystrophy, we see more changes in this layer than in the other stromal dystrophy. So again, a lot more to learn, and it's pointing clues in different directions which need to be followed.
Yes,
can I ask a question, Dr. Mehta? Yeah, Professor Dua, wonderful talk. I was totally glued to my screen. Thank you so much. So my question is that, see, in DMEK, we see that with the age of donor matters a lot in the scrolling. So in later age group, we have less scroll as compared to the younger one. So what happens to the elastin? Is it the distribution in the Descemet layer? Or, the elastin per se gets decreased? What happens?
So it can be both. Surprisingly, we're doing another study again, very exciting work, which I won't tell you anything about yet. But in a 90-year-old, we got a very tight scroll, right, in the donor eye. So it is not just the elastin and whether it becomes less or more, but it is also the thickness of the Descemets underneath. So if I take a cardboard and stick the rubber band, it's not going to roll. But if I take a paper and stick the rubber band, it's going to roll, unless I take a very heavy tire tube of a card and stick it. So the rigidity of the bulk of the stroma of the Descemets membrane and the elasticity both play a role in the scrolling. So the elasticity may be exactly the same, but this becomes thicker, as you saw in those pictures. It's not going to roll as much. So there are these two elements to why you get more or less scrolling.